Hello student, today I am going to teach you about the vasculitis. So vascular pathology is responsible for more morbidity and mortality than any other category of the human disease. So you will discuss about the vasculitis. So vasculitis means there is inflammation of the vessels wall. So vessels of any type in virtually in any organ can be affected, but most vasculitis affect small vessels ranging in size from arterioles to capillaries to venules. Usually two common pathogenic mechanism of vasculitis. One is the non-infectious or immune-mediated vasculitis or the inflammation of the vessels wall, and other is the infectious vasculitis in which there is direct invasion of the vascular wall by the infectious pathogens. So classification depending upon the or based upon the etiology, one is the primary vasculitis and other is the secondary vasculitis. So primary vasculitis occur in absence of recognized precipitating factors, and secondary vasculitis usually associated with a secondary to established disease, secondary to infection, secondary to malignancy, or secondary to drugs. So these are the different types of vasculitis. One is the large vessel vasculitis, medium vessel vasculitis, and a small vessels vasculitis. So these are the different form of the vascular pathology, and the branches. One is the aorta that may give rise to arteries, to arterioles, capillaries, venules, and vein. In large vessels vasculitis usually affect the large arteries. So in the this condition, usually there is a glomerular disease like a giant cell arthritis and Takayasu arthritis. In medium vessels vasculitis, medium vessels vasculitis usually associated with a immune complex mediated like a polyarthritis nervosa, and other is the anti-endothelial cell antibody associated like Kawasaki disease. In a small vessels vasculitis, one is the immune complex mediated like SLE, IgA nephropathy, cryoglobulinuria, and good pasture disease. So in the small vessels vasculitis, other is the ANCA associated vasculitis. So in ANCA associated vasculitis, there is a vasculitis without the asthma or granuloma formation like microscopic cholangitis, granuloma with a but there is a no asthma like Wagner glomerulosis, and in the Gastro Syndrome there is a eosinophilia, asthma, and granuloma formation. So these are the main the three types of vasculitis: large vessel vasculitis, medium vessel vasculitis, and vessel vasculitis. Classification depending upon the vessel size is the large vessels, medium size vessels, and small vessels vasculitis. So example of the large vessel vasculitis are giant cell arthritis, Takayasu arthritis. In medium size vessels vasculitis, polyarthritis nodosa or PAN, Kawasaki disease, and primary glomerular CNS vasculitis. In a small vessels vasculitis, ANCA associated vasculitis, immune complex, a small vessels vasculitis, paraneoplastic, a small vessels vasculitis, and inflammatory bowel disease vasculitis. So the small vessel vasculitis may be the ANCA associated, immune complex mediated, and paraneoplastic. In ANCA associated, there is microscopic cholangitis, Wagner glomerulosis, Gastro Syndrome, and drug-induced ANCA associated vasculitis like propyl thiouracil and hydralazine are the drugs that may lead to the ANCA associated vasculitis. Immune complex mediated like cryoglobulin vasculitis, Hennecaspalan purpura, lupus vasculitis, urticarial vasculitis, good pasture syndrome, serum sickness vasculitis, and drug-induced immune complex vasculitis. In paraneoplastic small vessel vasculitis, usually the lymphoproliferative or the myeloproliferative or the carcinoma-induced vasculitis. So the vasculitis, the classification. So what are the different form of the artery which are involved in different types of the vasculitis? In the large vessel vasculitis usually involve the aorta and the great vessels like subclavian and carotid artery, and usually features involve or features are usually claudication, blindness and stroke. In medium vessel vasculitis usually involve the artery with muscular wall, and there is mononeuritis multiplex that may lead to the wrist drop or the foot drop, mesenteric ischemia or cutaneous ulcer. In a small vessels vasculitis usually involve the capillaries, arterioles and venules, and the features usually are the palpebral purpura, glomerulonephritis and pulmonary hemorrhage. Now, what are the pathogens behind the vasculitis? So, pathogenesis. So, suppose antigens like microbes, drugs, tumors, or the autoantigens that may combine with the antibody of the and may lead to the formation of immune complexes. So, antigen and antibody both combine to form the immune complex, and that immune complex deposited in and around the blood vessels. So that immune complex lead to the activation of complement cascade and generation of C3 and C5a complements of the anaphylaxis. So there is mast cell degranulation and generation of the chemokines and the cytokines, and these chemokines and cytokines lead to the increased vascular permeability, neutrophil chemotaxis, and further deposition of the immune complexes. Finally, there is appearance of the neutrophils with phagocytic activity and release of proteolytic enzymes like collagenase and elastase. And these proteolytic enzymes lead to the destruction of the vessels and formation of the platelet thrombi. And finally, there is ischemia, hemorrhage, and necrosis of the tissue which are involved, and there is a appearance of the clinical sign and symptoms. So these are the pathogenesis behind the vasculitis. Now come to the one by one. So first one is the large vessel vasculitis. Vessel vasculitis. So one is the giant cell arthritis, that is also known as temporal arthritis. So it is a chronic inflammatory disorder of large to a small size artery that principally affect arteries in the head, especially the temporal artery, but also be vertebral and ophthalmic arteries are involved. Ophthalmic artery involvement can lead to the permanent blindness. Giant cell arthritis is a medical emergency that requires prompt recognition and treatment. Arthritis and the polymyalgia rheumatica, so usually involve temporal artery and the cranial artery, inflammation of the medium and large size artery. Temporal artery involvement, aorta and its branches may involve. In polymyalgia rheumatica, there is a pain in the muscles of the neck, shoulder muscles and lower back muscles. Pain may occur, usually involve more than 50 years of the age. In pathogenesis, usually there is T cell mediated immune response against the one of the handful of the vessels wall antigen that drives subsequent pro-inflammatory cytokine production, particularly the tumor necrosis factor, and other is the anti-endothelial cell and anti-smooth muscle cell antibody can also be demonstrated in the 2/3 of the patient, although it is unclear whether these are causal or a consequence of the other immune injury. So there is a cellular immune etiology is supported by the characteristic granulomatous response and a correlation with certain MHC class second haplotypes and promote therapeutic response to the steroids. In morphological features, there is a intimal thickening with occasional thrombosis that reduce the luminal diameter, and classical lesion exhibit medial glomerular inflammation centered on the internal elastic lamina that produce elastic lamina fragmentation. There is infiltration of the T cells, CD4 and CD8 T cells and macrophages. Although multinucleated giant cells are also seen in approximately 75% of the biopsy specimen. Glomena and giant cell can be rare or absent. Inflammatory lesions are only focally distributed along the vessels, and long segments of relatively normal artery may be interposed. The healed stage is marked by medial attenuation and scarring with intimal thickening, typically with a residual elastic tissue fragmentation and adventitial fibrosis. Now the clinical and laboratory investigation like fever, fatigue, weight loss, anemia, increase in erythrocyte sedimentation rate, headache, temporal artery may be the tender, thickened, nodular, and ischemic optic neuropathy may lead to the visual loss and blindness, increased risk of aortic aneurysm, or there may be the dissection of the aortic aneurysm, diagnosed usually by biopsy of the temporal artery and giant cell arthritis. So here we see these are the in diagram. In the one there is a temporal artery of a patient with giant cell artery arthritis, so a thickened nodular and tender segment of a vessels on the surface of the head. And the second picture, there is a hematoxylin and eosin stain of the section of the temporal artery showing giant cell at the degenerated internal elastic lamina in the active arthritis. So arrow that show the degenerated internal elastic lamina. So the elastin stain. So these are the specific stain that demonstrating the focal destruction of the internal elastic lamina and intimal thickening. So these are the characteristic of the long standing or the healed arthritis. Now come to the Takayasu arthritis. So Takayasu arthritis, it is a granulomatous vasculitis of medium and large arteries characterized principally by the ocular disturbances and marked weakening of the pulses in the upper extremities. Hence, it is also called pulseless disease. So there is transmural fibrous thickening of the aorta, particularly the aortic arch and the great vessels. So the gross and the histological picture. In the diagram A, there is a aortic arch angiogram that show the narrowing of the brachiocephalic carotid and subclavian artery. In the diagram B, there is a gross photograph of the two cross section of the right carotid artery taken at autopsy of the patient shown in the diagram A, demonstrating the marked intimal thickening with a minimal residual lumen. In the histological view of the active Takayasu arthritis, there is a destruction of the arterial media by mononuclear inflammation with giant cell. So mononuclear inflammatory cells like plasma cells, lymphocytes and macrophages seen. Now the frequency of the angiographic abnormalities usually involve 93% cases. In cases there is a subclavian artery, common carotid artery in 58% cases, abdominal aorta in 47% cases, aortic arch in 35% cases में, vertebral artery in 35% cases में, pulmonary artery in 10 to 40% cases में, and coronary artery usually involved in the less than 10% cases observed. So these are the different frequency of the involvement that are seen by the angiographic. Now the clinical manifestation of the Takayasu arthritis. So there is a pain arthritis with inflammatory mononuclear cell infiltrate, narrowing of the lumen, pulses are absent, increased ESI, anemia, and increased gamma globulin. Diagnosis: usually affected persons are usually young women. Decrease or absence of the peripheral pulses. There is a discrepancy in the blood pressure. Arterial broods may be heard. In arteriography, there is a irregular vessel wall, stenosis, post-stenotic dilation, aneurysm formation or occlusion, and evidence of the increased collateral circulation may be seen. Now come to the Bettiah disease. So Bettiah disease, it is a small to medium vessels neutrophilic vasculitis that classically present as a clinical triad of recurrent oral ophthalmos, genital ulcers, and uveitis. Now come to the others. Second is the medium vessels vasculitis. So in the medium vessel vasculitis, one is the polyarthritis nodosa. So PAN. So PAN is a systemic vasculitis of the small or medium sized muscular artery, but not the arterioles, capillary or the venules. Typically involve the renal and visceral vessels, but sparing the pulmonary circulation. It is the multi-system necrotizing vasculitis and not associated with ANCA, antinuclear cytoplasmic antibody. It is very uncommon disease. So pathology and pathogenesis. So the PAN is the segmental lesion and usually involve the bifurcation and branching of the artery. Aneurysm dilation may occur up to 1 centimeter in size. In kidney, there is a arthritis without glomerulonephritis, and 10 to 30% of the cases usually associated with hepatitis B, and there is a circulating immune complex deposition that composed of hepatitis B antigen. In clinical manifestation, there is a fever, weight loss. In kidney, there is a renal failure, hypertension. Joint, there is arthritis, arthralgia, myalgia, peripheral neuropathy, and mononeuritis multiplex. In GI, there is abdominal pain, bleeding, bowel infection and perforation. Liver infection and pancreatic infection may occur. In skin, there is a purpura, nodules development, cutaneous infarct, livedo reticularis. In heart, there is a congestive heart failure, myocardial infarction, and pericarditis. In testicular and ovarian pain may occur. In CNS, there is a cerebral vascular accident, seizures, and altered mental status. So these are the different clinical manifestations of the polyarthritis nodosa. In laboratory investigation, there is an increased leukocyte count, so there is a leukocytosis, increased ESR, anemia of the chronic disease like normocytic, normochromic anemia, there is hypergamma-globulinemia, and 10%, 30% of the cases show the HBsAg positivity. Diagnosed usually by vasculitis on biopsy material of the involved organ. In angiographic study, there is an aneurysm of the small and medium sized arteries are usually seen. So these are the histopathological picture of the PAN. So there is a segmental fibrinoid necrosis and thrombotic coagulation of the lumen of this small artery. Now come to the Kawasaki disease. So Kawasaki disease, it is a acute febrile, usually self-limited illness of the infancy and childhood. 80% are younger than the 4 years of age. Arthritis affecting large to medium sized artery and even small vessels associated with mucocutaneous lymph node syndrome, and coronary arteries are often involved. Aorta and large artery may be involved. Clinical features. The Kawasaki disease is also known as mucocutaneous lymph node syndrome because the patient present with conjunctival and oral edema and erosion, edema of the hands and feet, edema of the palm and sole, cervical lymph node enlargement. In clinical features, 20% of the patient develop cardiovascular sequelae like asymptomatic coronary arteritis to coronary artery ectasia and aneurysm formation to the giant coronary artery aneurysm. the size is aneurysm is 7 to 8 millimeter in diameter with rupture or the thrombosis, myocardial infarction, and sudden death may occur in 20% of the patient that having the disease. So these are the histopathological picture of the Kawasaki disease. Now come to the thromboangiitis obliterans, that is also known as the Burger disease. So thromboangiitis obliterans or the Burger disease, it is a segmental occlusive inflammatory condition of the arteries and vein characterized by thrombosis and recanalization of the affected vessels. It is non-atherosclerotic inflammatory disease affecting a small and medium-sized artery and vein of the upper and lower extremities. The etiology of the Burger disease is unknown, but use or exposure of tobacco is central to the initiation and progression of the disease. So Burger disease usually is a disease of the smokers and usually involved in the chronic smokers. So in morphology, there is a focal, acute, and chronic vasculitis of the small and medium-sized arteries, predominantly the extremities. Acute and chronic inflammation accompanied by luminal thrombosis. The thrombus can contain a small microabscess composed of neutrophils surrounded by glomerulus inflammation. So in the diagram, these are the histopathological picture that show the acute and chronic inflammation accompanied by luminal thrombosis. Typically, the thrombus contains a small microabscess composed of neutrophils surrounded by glomerulus inflammation that are seen by the arrow. Now the clinical feature, the early manifestation may have the cold-induced Raynaud phenomena, leg pain induced by exercise that is relieved by on the rest, that is known as the intermittent claudication. In a step, foot pain induced by exercise, so that is known as in-step claudication, and a superficial nodular phlebitis. So the early manifestation may be there is a Raynaud phenomena, intermittent claudication, and in-step claudication. In chronic phase, there is a development of ulceration progressing over the time to the frank gangrene. Smoking, obscenity in early stages of the disease can often ameliorate further attack. However, once established, the vascular lesion typically do not respond to smoking obscenity. Now come to the small vessels vasculitis. So these are the example of a small vessels vasculitis. So in the previous slide, you discuss about the small vessels vasculitis. So a small vessels vasculitis usually associated with ANCA associated, and other is the immune complex associated. So in the ANCA associated vasculitis, one is the organ limited post-immune vasculitis. So there is a organ limited post-immune vasculitis. In other, there is a no glomerular inflammation or the asthma, that is microscopic cholangitis. In regular glomerulosis, there is a glomerular inflammation, but there is a no asthma. But in Churg, glomerular inflammation, asthma, and eosinophilia. So these are the ANCA-associated small vasculitis. So small vasculitis, one is the ANCA associated and other is the immune complex associated vasculitis. So one is the GPA, that is the glomerular polyangiitis or the ulnar glomerulosis, MPA microscopic polyangiitis, and EGPA like eosinophilic glomerulomatosis polyangiitis or the Gastro Syndrome. In immune complex small vasculitis, one is the anti-GBM, IgA nephropathy or hematoxylin purpura, cryoglobulinemic vasculitis, and hypocomplementary arterial vasculitis. So these are the different example of the small vessels vasculitis. So now the ANCA antibody, that is the anti-neutrophilic cytoplasmic antibody. So these antibody is specific to the antigen of the neutrophil granules and to the lysosome of the monocyte. So these ANCA antibody may be the two types. One is the C ANCA, another is the P ANCA. The C ANCA is the cytoplasmic antibody, and P ANCA is the perinuclear antibody. So there is many different antigen in the group C or P, but the most important are the proteinase 3, myeloperoxidase, MPO, lactoferrin, catepsin G, elastase, lysozyme, and azurosidine. So these are the different types of the antigen that are found in the cytoplasmic or the perinuclear region. So ANCA positive vasculitis are the C ANCA, P ANCA, and in immunofluorescence determine the group C or P. ELISA distinguishes the precise antigen PR3 or MPO which are associated with ANCA antibody. Now the C ANCA difference so between the C ANCA and P ANCA. So C ANCA are the serum from the patient bind to the cytoplasmic granules and show a granular appearance on the immunofluorescence. So C ANCA usually are the that contains the proteinase 3 or PR3 is the major antigen. So in this type of antigen there is enzymes are the serine protease and present in the azurophilic granules. In P ANCA localized in the perinuclear region and a staining pattern on the polymorphonuclear leukocytes. These are the myeloperoxidase or MPO is the major antigen and normally involved in the generating the oxygen free radicals and present in the lysosome. So these are the difference between the C ANCA and P ANCA and their location and releasing of the enzyme and involved in the different disease condition. Now the mechanism associated with ANCA vasculitis is the following. So drug or cross-reactive microbial antigen induces the ANCA. So neutrophil surface expression or release of PR3 and MPO in the setting of the infectious agent may lead to the ANCA formation in a susceptible host. So there is subsequent infection, endotoxin exposure, or the other inflammatory stimuli may lead to the release of cytokines such as TNF that cause surface expression of the PR3, MPO on neutrophil and other cell types. These ANCA react with these cytokine activated cells and either cause direct injury to the endothelial cells or induce further activation in the neutrophils. So ANCA activated neutrophils degranulate and also cause injury by releasing the reactive oxygen species and engendering endothelial cell toxicity and other indirect tissue injury. So these are the pathological mechanism or the pathogenesis of the ANCA associated vasculitis. So how ANCA lead to the cell injury or the tissue injury. So in the small vessel vasculitis, one is the Wagner granulomatosis. So Wagner granulomatosis, it is a necrotizing vasculitis characterized by a triad of acute necrotizing granuloma of the upper respiratory tract that may involve the ear, nose, sinuses, throat, or the lower respiratory tract like lung or the both. And second is the necrotizing or glomerular vasculitis affecting the small to medium sized vessels, and third is the renal disease in the form of focal necrotizing, and often there is a eccentric glomerulonephritis. So these are the necrotizing vasculitis and have the characteristic of triad of these three. Now in the Wagner granulomatosis there is a primary vasculitis syndrome that may lead to damage of the vessels. These are the immunopathogenic mechanism, and there is a PR3 ANCA are present in up to 95% of the cases. Detectable antibody to the proteinase 3, and there is a granuloma formation. So in pathology and pathogenesis, there is a T-cell mediated hypersensitivity reaction to an inhaled infectious or other environmental agent. So there is necrotizing vasculitis of the small arteries and vein, and there is granuloma formation. In lung, there is a multiple bilateral nodular cavity infiltrates. In biopsy, there is a necrotizing glomerular vasculitis. In upper airway region, sinuses and nasopharynxes. In kidney, there is a rapidly progressive dysentery glomerulonephritis. Clinical manifestation usually involve age around 40 years of age. Male are predominant than the female, and classical features are usually there is persistent pneumonitis with bilateral nodular and cavity infiltrate that may seen in 95% of the cases. Purulent and bloody nasal discharge, nasal septal perforation, saddle nose deformity, serous otitis media, and hearing loss. In eye, there is a scleritis, conjunctivitis, retroorbital mass lesion. In skin, there is palpable purpura, papules, vesicles, and subcutaneous nodules. In heart, there is pericarditis and coronary vasculitis. In CNS, there is mononeuritis multiplex and cerebral vasculitis. In kidney, in 77% of the cases, there is a proteinuria, hematuria, red blood cell cast, and rapidly progressive renal failure may occur. So these are the diagram that show the different features of the Wegener glomerulomatosis. So Wegener is the infamous for its subtle presentation and its lethality. If it is not correctly diagnosed and treated, it is caused by autoantibody against the proteinase 3. So in the diagram, so there is a positive C-ANCA or anti-neutrophilic cytoplasmic test. In the second diagram, there is a formation of granuloma and patchy necrosis in the artery and vein, and these are the clinical manifestations like sore eye, sore ear, stuffy nose. There is a destruction of the face, lung cavity and bleeding, permanent kidney damage and kidney failure. There is development of gangrene. There is a blood in the urine, sore joint, and abnormal chest X-ray. So these are the different clinical manifestation and of the Wegener glomerulomatosis. In laboratory, there is increased ESR, mild anemia, leukocytosis, thrombocytosis. 90% of the positive cases are the C-ANCA proteinase 3 positive. In diagnosed by the tissue biopsy. In tissue biopsy, there is a necrotizing glomerular vasculitis and C-ANCA positivity. Now come to the Gastro Syndrome, also called allergic granulomatosis or the Genitis. It is relatively rare condition and onset occur usually 48 years of age and usually involve the small and medium vessels necrotizing vasculitis associated with asthma, peripheral and tissue eosinophilia, vasculitis of the multiple organ. Extravascular granuloma formation may be seen and there is infiltration of the tissue with eosinophils. In clinical and laboratory manifestation are the asthma, pulmonary infiltrates, mononeuritis multiplex, allergic rhinitis and sinusitis. In skin lesion, there is purpura, subcutaneous nodule, eosinophilia, increased ESR and P-ANCA positivity. In histopathological picture, there is a lung and extrapulmonary sites like skin, heart, nervous system, GI are prominent eosinophils that show the prominent eosinophilic infiltrate glomerular reaction around the necrotic foci with readily arranged histiocytes and palisading giant cell near a small arteries or the arterioles and eosinophilic vasculitis. So in the diagram, there show the small vessels and that are the different patches of the eosinophilic infiltrates may have the fibrinolytic edema, lymphocytes and sarcoid-like granuloma, focal fibrosis and eosinophilic microabscess formation may occur. So these are the histopathological picture of the Gastro Syndrome. Now come to the microscopic polyangiitis. So the microscopic polyangiitis, these are the necrotizing vasculitis affect the capillaries as well as arterioles and venules of a size smaller than those involved in the polyarthritis nodosa. Rarely, larger artery may be involved. It is also called hypersensitivity vasculitis or the leukocytoclastic vasculitis. So in the pathogenesis, an antibody responds to the antigen like drugs, penicillin, microorganism like a streptococci, and heterologous proteins or the tumor protein that may result in formation of immune complex deposition or may trigger the secondary immune response and development of the PNK that are ultimately the pathogenic. In morphology and clinical feature characterized by the segmental fibroid necrosis of the media with focal transmural necrotizing lesion. So lesion morphologically resemble the polyarthritis nodosa but typically spare the medium size and large arteries. Glomerular inflammation are usually absent and major clinical features are the hemoptysis, hematuria and proteinuria, bowel pain and bleeding, muscles pain or weakness and palpable cutaneous purpura. In the microscopic cholangitis, the gross and microscopic pictures are the vasculitis of a small artery with adjacent glomerular inflammation, including the epithelioid cells and giant cells in the first picture, and the gross there is a gross photo from the lung of a patient with a fatal vaginal glomerulosis demonstrating the large nodular centrally cavitating lesion. Now the infectious vasculitis in the previous slide. So these are the infectious vasculitis. So infectious vasculitis is caused by the direct invasion of the infectious agent, usually the bacteria or fungi, and particularly the fungi are aspergillus and mucor species. The vascular invasion can be part of a localized tissue infection like bacterial pneumonia or the adjacent abscess from hematogenous seeding of the bacteria during septicemia. Embolization from the sepsis of the infective endocarditis may occur. So these are the different route of the infection that may lead to the infectious vasculitis. Vascular infection can weaken arterial walls and ultimately lead to the formation of mycotic aneurysm and can induce thrombosis and infection. So these are all about the vasculitis like infectious vasculitis and non-infectious vasculitis. Thank you. In the next class, we have to discuss about the atherosclerosis.